We will continue the prostate cancer part 8, and previously we speak about the seminal vesicles biopsy. So we consider performing seminal vesicle biopsy in the following situations. A large cancer in the base of the prostate, the seminal vesicles, base of the prostate, seminal vesicles invasion is more likely when there is large cancer in the base of the prostate. So BSA 15 seminal vesicles involvement. So BSA is 15. The seminal vesicles involvement is 20 to 25% with BSA more than 15. A nanogram predicted a high risk of seminal vesicles invasions. Imaging suggests the presence of the cancer in the seminal vesicles invasion is more likely in men whose ultrasound show hypoechoic lesions in the base of the prostate or hyperechoic lesions in the seminal vesicles. So if we find in the imaging ultrasound that's hyperechoic in the seminal vesicles or hypoechoic lesion in the base of the prostate, so this suggests us the presence of the cancer in the seminal vesicles. Loss of the normal echogenic fat between the prostate base and seminal vesicles, the posterior, that's a rectal surface of the seminal vesicles is convex toward the rectums, or the seminal vesicles is displaced anteriorly more than 1 centimeters from the rectal wall. This is loss of normal echogenic fat between the prostate base and the seminal vesicles, also considered as risk factor for invasion. Biopsies should be concentrated in the proximal third of the seminal vesicles, that's a part close to the prostate. Sample as close as possible to the junction of the seminal vesicles and prostate without sampling the prostate. So the sample must be close as possible to the junction of the seminal vesicles. When the prostate cancer invades into the seminal vesicles, as the initial site of invasion is almost always proximal seminal vesicles. So the proximal seminal vesicles is almost always site of invasion of prostatic cancer. Distal seminal vesicle invasion, in the absence of the proximal seminal vesicle invasion, is rare. A spread of prostate cancer into the distal 1 centimeter of the seminal vesicle is also rare. So in the paramedian plane, the biopsy needle tip is advanced through the rectal wall and positions few millimeter posterior to the proximal seminal vesicles. Then the biopsy gun is fired. Attempt to sample the entire anterior prostate distance of the seminal vesicles. The needle should not penetrate into the prostate, the bladder lumen, or the peritoneum. So this is a seminal vesicle biopsy. And as you see here, this is the most common location of the seminal vesicles invasion. That's the proximal side. This is the proximal side, the proximal to the prostate. So it's the proximal to the prostate. This is considered as the most common site of invasion. And we mentioned previously that is the proximal site of invasion. It is common that the seminal vesicle involvement is 20 to 25% with PSA of 15. And also we mentioned that usually the site of invasion displaced anteriorly more than 1 centimeter from the rectal wall. And so this is prostate depicted in the coronal plane, and this is in the sagittal paramedian plane. Okay, so this is peripheral zone, central zone, and transitional zone. This is the seminal vesicle, this is the proximal, and this is the distal part. Multiparametric MRI guided prostate biopsy. A normal prostate multiparametric does not exclude the prostate cancer. If the prostate cancer, prostate multiparametric MRI is normal, but they suspicious of the prostate cancer, then systemic biopsy should be performed. There are three techniques for performing multiparametric MRI guided biopsy. I mean, the biopsies that target a suspicious area on the multiparametric MRI. In bore multiparametric MRI guided biopsies are done within the patient in the MRI gantry. That the MRI image confirms that the biopsy needle is placed into the target. Okay. The procedure is time consuming and require the patient to be in the prone position for prolonged period. So trust multiparametric MRI fusion guided biopsy using the multiparametric MRI an outline of the prostate and suspicious lesion are constructed within the computer. Prior to the biopsy procedures, this data is loaded into the fusion system at the time of the biopsy procedures. The urologists use the fusion systems to align the prostate on the truss image and the multiparametric MRI image so that they track together in the real time. The lesion outline from the multiparametric MRI is then overlaid onto the real-time truss image, which allowed the clinician to target the lesions that was seen on a multiparametric MRI. Cognitive fusion guided biopsies, the clinician look at the multiparametric MRI image and create a mental map of the lesions locations within the prostate. Then the clinician performs truss-guided biopsy and targets suspicious area based on the mental map. The detection of the clinically significant cancer is similar regardless of which multiparametric MRI guided technique is used. Also, truss and multiparametric fusion MRI fusions and in-bore guided biopsy appear to be more reliable for targeting small lesion or lesion that are difficult to reach the location. Minimum number of core per lesions, the AUA in SAR 2016 guidelines suggest taking minimum of 2 core per lesions because the majority of the cancer can be detected within 2 cores. However, at least 9% of clinically significant cancer are missed only 2 cores. So AAU 2021 guideline recommend taking at least 3 core per lesions. To improve the diagnostic yield of the multiparametric MRI guided biopsy, taking 3 to 5 core per lesions may be best, especially for small lesion or lesion that are BIRADS more less than or equals 3. Detection of significant cancer. Multiparametric MRI guided biopsies detect fewer lesions less than or equal 6 cancer and more than lesion more than 7 or equal 7 cancer compared to systemic biopsies. Also, in biopsy naive men, the trend toward higher detection of lesion score more than or equal 7 cancer was not significant in all studies. In other words, multiparametric guided biopsy detect fewer clinically insignificant cancer, reducing over-detection and detect more clinically significant cancer, reducing the chance of missing, threatening cancer compared to the systematic biopsy. Nonetheless, MRI-guided biopsy can still miss some clinically significant cancer. In fact, multiparametric MRI-guided biopsy alone will miss approximately 5% of lesion 7 cancer compared to a combination of systemic and multiparametric MRI-guided biopsy. To maximize the detection of clinically significant cancer, systemic and multiparametric MRI-guided biopsy can be combined. Many studies have shown that performing systematic and targeted biopsy together increase detection of clinically significant cancer compared to either type of biopsy alone, but it will also increase the number of clinically insignificant cancer that are detected. For men who are biopsy naive, the AUA and SAR 2019 EAU 2021 and NCCN 2021 guideline recommended combining systematic and multiparametric MRI guided prostate biopsies. AUA and SAR 2019 use of systematic biopsy in conjunction with multiparametric MRI targeted sampling is advisable until the time that individual experience demonstrate a low risk of missed clinically significant cancer. EAU 2021, when multiparametric MRI is positive, mean that's BIR ADS less more than or equal 3, combine targeting and systematic biopsy. The NCCN 2021 most expert advocate for combined approach, both targeted and systematic sampling, as some higher grade cancer are uniquely detected using the systematic approach. For men with period negative biopsy, the EAU 2021 guideline recommended performing only a targeted biopsy, where the AUH SARS 2019 guidelines said that the combined systematic and multiparametric MRI guided biopsy should be performed until quality assurance effort have validated the performance of prostate multiparametric MRI interpretations with the result consistent with the published literatures. And if this is a case, then only targeted biopsy can be performed. Re-biopsy after previous negative biopsy. Re-biopsy is performed in men suspected of having prostate cancer despite previous benign biopsy. So we'll do re-biopsy if we have suspicious of prostate cancer despite benign biopsy. Reasons for suspected prostate cancer in this setting may include a rise in total PSA and also change in digital rectal examination and previous biopsy finding that's multifocal high-grade PIN or atypical small acinar proliferation or other test results that like confirm MDX or BCA3 positive in benign biopsy or in benign fissions of the biopsy. Atypical systematic 12-core biopsy will miss a clinically significant cancer approximately 20 to 30% of the time. So 20 to 30% false negative in atypical systematic 12-core biopsy. When cancer is missed on the initial systematic biopsy, the cancer is usually hiding in one of the following locations: anterior apical peripheral zone, midline peripheral zone, or anterior transitional zone. So this is cancer missed at the initial systematic biopsy. The cancer usually hiding in this place or in these sites: anterior apical peripheral zone, or midline peripheral zone, or anterior transitional zone. The minimum sampling on the systematic re-biopsy should include the same scheme recommended for initial biopsy, but also consider obtaining core for the transition zone, midline peripheral zone, and anterior apical prostate. Transurethral biopsy, transurethral resection of the prostate is usually not utilized to biopsy for prostate cancer because it is a low diagnostic yield. It detects prostate cancer in less than or equal 10% of the cases. The transitional zone can usually sample adequately by transrectal or transperineal biopsy. Systematic saturation biopsy and abundance of a core, that's example more than 20, are taken throughout the prostate. Saturation biopsy may be performed transperineal using brachytherapy templates or transrectal. Saturation biopsy is alternative to repeating a standard 10 to 12 core systematic biopsy. A method to help determine the needs for repeat biopsy after period benign systematic biopsy. Multiparametric MRI of the prostate in men with raising PSA or high risk of prostate cancer despite previous benign prostate biopsy. Prostate multiparametric MRI may help identify cancer that has been missed. multiparametric MRI can also be used to guide biopsy into the suspicious region. Several studies show that the cancer detection rates are higher within the targeted biopsy than with systemic biopsy. Systematic biopsy. Also, cancer detection rates are highest when systematic and targeted biopsy are performed together. So in the detection rate is high with targeted biopsy than in systematic biopsy, or it's higher or highest compared with using both methods together. If biopsy of BIRADS5 lesion is benign, consider repeating the multiparametric MRI and multiparametric MRI guided biopsy take at least 3 to 5 core from the lesion. Because there is still high likelihood of cancer, even when the repeat multiparametric MRI show that the lesion has improved to BIRADS2 or 3, the risk of finding cancer on repeat biopsy is nearly 25%. So if the repeat multiparametric show the lesion is still BIRADS4 or 5, then the risk of finding cancer on repeat biopsy is